Hi, everyone. So I would like to give a brief overview of panic disorders today. And this is just a psychiatrist's perspective of how we approach panic disorders clinically. So the building block of a panic disorder is a panic attack. And these are not the same thing. A panic attack is different from a panic disorder. And the question is, what is a panic attack? Patients say this a lot. When you ask about panic attacks, they say they've had one, and it's important to clarify what this is, because not every increased episode of anxiety necessarily means that that is a panic attack. So a panic attack is an abrupt surge of intense fear and discomfort. This is an episode or a state where one has a very significant spike in anxiety, and it's very technically defined. Usually it happens abruptly and it tends to peak within minutes. And then the whole event, at least the most intense aspects of it, subsides, usually within 45 minutes or an hour. And there are very specific symptoms to look at. So there is a surge of fear, and there a combination of physical symptoms and psychological symptoms. The physical symptoms manifest as a kind of fight or flight activation, or rather an activation of your sympathetic nervous system. And that encompasses a multiplicity of your various organ systems. So it encompasses hyperactivity of your respiratory system, which could manifest as hyperventilation, that is shortness of breath, like when you breathe very quickly. It could manifest, or it could also include your cardiovascular system, your heart. You could feel your heart racing. You could feel palpitations. It could include your nervous system. You could feel tingling sensations, dizziness. It could include your gastrointestinal tract, where you could experience nausea. And also, can mention there's a psychological aspect where one have an intense subjective experience of fear. Some people might feel like as though the world is about to end or something really bad is about to happen. They might have a dissociative reaction where it feels like as though they are in a dream of sort. So there are all these symptoms you could have. And if we were to be very systematic, to define this very technically, you need at least 4 of those symptoms that is listed there. Now, there are episodes where one might have this surge or this abrupt surge of an experience of anxiety that doesn't quite rise to the level of a panic attack, where you have some of these symptoms mentioned, but you don't really have 4 of these symptoms. Those episodes that are sub-threshold, that do not rise to the level of a panic attack, are called limited symptom attacks. So once again, not every surge of anxiety one experiences is a panic attack. That's a panic attack. So one could have a panic attack in one's life. That does not mean you have a panic disorder. So what then is a panic disorder? When do we say someone meets criteria of a panic disorder? Well, you need to have had a panic attack in the past, and not just one, but this is when you have recurrent, usually unexpected panic attacks. So that's the other thing. Panic attacks could be expected or unexpected. Expected is when there's usually a very clearly defined trigger. But when there is no clearly defined trigger, it's unexpected. And that's one of the characteristics of a panic disorder. But it's not just that. It's also that one would have episodes or feelings or this anticipatory anxiety or fear of having another panic attack. And this state of fear of having future unexpected panic attack usually would last for at least a month. So at least one attack is followed by 1 month of persistent worry, maladaptive change in behavior related to the attack. That is basically, not only do you worry about having another attack, you start organizing your life around that fear. So if, for instance, you had a panic attack in a specific place, say in the mall, one would feel a lot of anxiety going to the mall, or one would try to avoid malls. because you're scared you're going to have a panic attack in that environment. And this should not be due to substance use or to any other medical or mental disorder. So if one is diagnosed with panic disorder, what is the expected trajectory across one's life or one's lifespan? They tend to begin in the mid-20s. With all these disorders, there's always variability, but that is just an average. It might be related to an adverse life event. Sometimes they have no particular trigger. I've had patients who have tried psychedelic substances, and from that one experience, they had a bad trip. That is, they had an overwhelmingly negative experience, and because of that, they subsequently, from that one experience, would have episodes of panic attacks and just constant fear of having a recurrence of a panic attack, which would then qualify for a panic disorder. And across one's life, the panic attacks come in episodes. Well, while there's this baseline fear of having another attack, usually, like we mentioned, the panic attacks are very, very short. The span is very short, and they occur like usually within an hour. Some patients say that the panic attack has extended for hours and even days. That's possible that they're in an elevated state of anxiety, but it's not likely that you could have that heightened state that would qualify as a panic attack for periods of time extending beyond 1 hour. But overall, even though you don't ever really cure panic disorder per se, it tends to be chronic, but the episode fluctuates across one's life. And there's an increased risk of having medical conditions like myocardial infarction, cardiovascular disorders, and so on. And panic disorder, as with a lot of anxiety disorders, tend to occur a lot with major depressive disorder. That's what MDD means, as well as alcohol use disorder. And how do we treat panic disorder as a psychiatrist? Well, with the vast majority of mental disorders, we always think of two things: medication and therapy. And in this case, the medication of interest are SSRI, serotonin selective reuptake inhibitors, and they help prevent panic attacks in a good percentage of patients. There are some specific SSRIs that are FDA approved: Prozac, Paxil, Zoloft. And you would want to dose these medications the way you would dose regular antidepressants. You want to take them for at least 1 year to prevent relapse. And if one has a relapse, say you stop taking the medication, because not all patients would want to take the medication for a long time. But if you stop the medication and one has a relapse, then you could always restart the medication that actually works for the patient. And there are other things one could use: benzodiazepines, propranolol. Not a fan of benzodiazepines. Well, there's this new generation of psychiatrists, myself included. We're just worried about the potential risk of abuse or substance abuse that could develop from a controlled substance like benzodiazepines. So benzodiazepines, they tend to work. They will shut down any rise in panic attacks, but if they have to be used, they have to be used carefully with proper psychoeducation, advising that this is to help. Usually, sometimes in the initial phases of the beginning of an SSRI, amongst a few things, SSRIs could paradoxically cause increased anxiety when you start them, and so that wouldn't be fun for someone with a panic disorder already. And so the benzodiazepines could be used in those initial phases to help mitigate the symptoms of anxiety, and also could help the patient as they build their skills. But you want to encourage the patient not to be too reliant on the benzodiazepine, just so they can build skills using therapy, which will be the next thing we'll touch on very briefly. Well, not just quite yet. And other things as well. You want to avoid caffeine. All those drinks have varying levels of caffeine in them. I did talk about propranolol. Propranolol is not used too often to treat panic disorders per se. However, there is something called performance anxiety. This is when people have a lot of anxiety when they perform, and propranolol seems to work if they take it like say an hour before their performance. And cognitive behavioral therapy tends to work for panic disorder, where they learn various skills, various ways of cognitive restructuring. That's the overview of the clinical approach, including the management of panic disorders. And I think, well, I guess I was going to talk about social anxiety in a different discussion, but that's all for now. Thank you for watching.